All right, good morning. We'll see what we can get through on this, and then we'll do the rest at another time. I'm Daryl Baskin. We're going to talk about AMD, some disclosures. All right, we got three guys here, Alex, Edward, and Richard, or Rich?
Yeah.
Okay, which one do you go by?
Rich.
All right, so we'll try to make this interactive and interesting. So we're not going to go into some philosophical thing about what AMD is, but have you guys raise your hand if you manage somebody with macular degeneration at this point? Are you guys second years, first years, third years?
Third year, first years.
Okay, you're a third year?
No, he's the third year.
You're a third year. Okay, these two are first years. All right. Okay, so you've definitely managed folks with AMD. What about you guys, first years?
Seen him.
Seen him, okay. So we'll I'll call on you guys a little bit just because it gets boring for me. Can we turn down these lights a little bit?
Yeah.
So macular degeneration, leading cause of blindness in the Western world in folks over 50, okay? And causes, dry AMD is found in about 11 million people in North America, and about 1.5 have the wet form, 11 million have the dry. This is mostly from the BCSC, and if it's not, then you'll see I'll have a little icon here so you don't have to memorize it. It's more prevalent the older you get. I don't think these numbers are true anymore, but this is what the book says. Over 65, it's a 10% prevalence, and over 75, it's a 25%. I don't believe that. And then we have all these additional risk factors listed: female, high blood pressure, high cholesterol, et cetera, et cetera. This is a study. This is not in the BCSC. It came out in 2017. This is looking at the Beaver Dam Eye Study and the Beaver Dam Offspring Study. This is out of Wisconsin. And if you look at it, that dark gray line in the upper right is from the folks that were born between 1901 and 1924, so the greatest generation. Pretty high prevalence, right? If you look down at the orange, that's the silent generation. Those are like, people born between the 20s to 40s. And then the baby boomers, it's lower. Now, again, we're looking at slightly younger populations. Generation X, you really shouldn't have macular degeneration before the age of 45. So Crookshanks looked at this data and then age adjusted it and sex adjusted it. And again, I don't believe the last one for Generation X because I don't really know how folks that are below 50 are going to have macular degeneration. But if you look at it, the greatest generation, about a 9%, I think I've got it on here, 9% prevalence or incidence of AMD within 5 years is actually what we're looking at, I think. And then it goes down to 3%. So it goes down by 65%. And then it goes down by another 65% or 67%. And then I don't believe the 0.3% because I don't think we in Generation X, myself, you guys are not in Generation X, are really old enough. Again, you can age adjust for something, but if it doesn't happen until after you're 50 for the most part, how do you really find it? The point is it's decreasing in incidence, which is really important. We don't know why that is. There's a lot of hypotheses and conjectures. The other thing that they found, let's see if I can go back to that slide, is that they didn't, after they adjusted for age and sex, there was no association with smoking, diabetes, high blood pressure, obesity, exercise, any of that stuff that I just mentioned on the previous slide. So it's all kind of still up in the air. We really don't know. My patients ask me all the time why they have it. It's mostly genetic, somewhat environmental exposure. There was a protective effect of multivitamin use and education level, believe it or not. So, okay, I'll go through that again. Sorry, one more thing. This is kind of my soapbox. They don't talk about it in the BCSC because it's a little bit controversial. That's my opinion. Also, it's fairly recent. But basically, there's a big cross-sectional study out of Europe showing that if you use aspirin, you have a doubled risk for wet AMD, 2.2 odds ratio. We have two longitudinal studies, one with 20 years of follow-up, one with 15 years of follow-up. Both of them say if you're taking aspirin, you have a double the normal risk of wet macular degeneration. We don't know why that is. I think it's a real number. I do talk about it with some of my patients. It's a big Pandora's box once you start discussing it. But the reality is if somebody is taking it for secondary prevention, they had a heart attack, stroke, I never tell them to change it. But if they're just taking it because their doctor said it's a good idea because they hit a certain age, the evidence for that is not very good, and you have a higher risk of GI bleeds and hemorrhagic stroke. So I tell them, talk to their PCP and talk about getting off of it. I never actually tell them to stop taking it. Okay, this is from the book. Some genetics. There's a bunch of different genetic loci where you can have disease-causing mutations that put you at higher risk for macular degeneration. Some people argue that it's more of a genetic disease than it is an age-related disease, and we should call it gene-related maculopathy. Suffice it to say, I don't know if you should memorize more than this, just these two genes, CFH, complement factor H, and ARMS2. They both put you at heterozygous levels at higher risk and homozygous levels. So if you have both of them homozygous disease-causing mutations, you've got a 50 times greater chance of getting macular degeneration than the average Joe. And I do see people in their 40s, late 40s typically at the earliest for me, I'm still sort of young in my career, that will have typical signs of dry macular degeneration without having one of the other, causes of drusen, etc. So dry AMD, the defining lesion is the druse, which you can see here. It's these little yellow-ish spots. We've got small, intermediate, and large. Yeah, there you go. Well, no, can they see my pointer somewhere else? Probably not. You guys could see it. And then you can get RPE changes, hyperpigmentation, hypopigmentation. The book talks a lot about laminar and linear deposits. I think that's sort of archaic. We don't really discuss that. It doesn't have prognostic significance for me anyway. But just having drusen alone can cause vision loss. And I think that's important to know because sometimes when somebody comes in with decreased vision, they may or may not have noticed. They're not necessarily great historians. But if you look and they've got a lot of drusen, look at these four things. You can have some vision loss, contrast sensitivity issues, color vision issues. One of the top things I hear from my patients is dark adaptation. They have a really hard time with that. They'll go into a restaurant and bring a flashlight with them because it takes them so long to be able to get to that, to see that menu well. And I don't have any treatment for that. I've got nothing that I could do for those signs and symptoms. I do think it's reasonable to know this sort of system, small, intermediate, large. And does anybody know of an anatomical marker that tells you it's approximately 125 microns in the back of the eye? Yeah, the vein, when it exits the optic disc, right at that margin, we say 125 microns. Of course, there's variability. Drusenoid PEDs, we generally consider those to be less than 350 microns in diameter, but you could think of it as just a large drusen or drusenoid lesion. Thanks. So we've got two folks, two different guys, I think they're both male, with some different sized drusen. And then on this next slide, I'll show you another one. Those are small, up at the top, white, and then red or large. And then these, again, 63 to 125 are the intermediates. And then I've got a drusenoid PED labeled here for you. So I think this is an important distinction. This is in the book. This wasn't something that was discussed much when I was a resident. There's an entity called a subretinal drusenoid deposit or a reticular pseudodrusen. Are you guys familiar with that term or those terms? They're synonymous.
Read about it.
Read about it. All right. So these little reticular pseudodrusen are smaller than soft drusen, or smaller than regular drusen that we just discussed, and they're located, if you look at the OCT, they're on top of the RPE. They're on the apical side, and they're more heavily distributed in the superior macula. And I'll show you a couple of examples. They don't contain outer disc segments, and they're associated with a worse prognosis, more atrophy of the photoreceptors, geographic atrophy, so RPE atrophy, and a higher risk of CNV, all bad stuff. I don't tell people frequently, oh, you've got RPD and this is going to be worse. But people do want to know, like, what's their prognosis. And for somebody like that, I might see them back a little more frequently than my typical sort of, dry or intermediate AMD patient. So on this top, this is the same patient, left eye. You can see all my little yellow arrows I put in there. They're usually regularly spaced from each other. And if you look at our inferior macula, the lower image, you'll just see like maybe three. And those three are really tough calls. I kind of really looked and tried to overcall it a little bit. Really, from here, it looks like there might be one. But in that upper slide, there's quite a few. That's a typical appearance. Medium reflectivity profile, mounds or cones right at the level of ellipsoid zone or just outside of the ellipsoid zone. And then with dry macular degeneration, I mentioned earlier, you can get RPE changes. Geographic atrophy for research purposes is greater than 175 microns in diameter. You don't need to memorize that. The book has a bad rate of progression listed, 1.79 millimeters squared per year. The best metric for measuring progression is actually an adjusted square root of the geographic area, because as it gets larger, you have a certain amount that is always growing. And if you think about it, that area that somebody with a large amount of geographic atrophy adds in 1 year is much greater than the person that a very small amount will add. It's sort of like, think of it as an annulus that kind of grows each year. Slow burning brush fires, the way I describe it to my patients. But if you take the square root, you're kind of eliminating some of that because you're looking more at kind of the radius enlargement in a sense. So 0.28 millimeters per year is the typical rate of progression. Here's a patient with RPE atrophy, geographic atrophy. They call it geographic because it's like a geographic boundary. You could draw a lot, take a line or take a pencil and be able to really well demarcate it. And you can see there's still a little bit of some foveal preservation, not much. And we've got some atrophy here. We'll define that in a moment. There's a differential diagnosis, of course. It's narrowed quite a bit, in my opinion, since we have OCT now. Well, we've had OCT for 20 years, but central series chorioretinopathy is still a possible confounder. Pattern dystrophy, adult onset vitelliform maculopathy, and drug toxicities, although I'd say the drug toxicities are really a non-issue for the most part. Adult onset vitelliform maculopathy can look a lot like SHRM, which we'll show you in a minute. So you really have to talk to them about their symptoms, and then there's a typical OCT appearance. So the AREDS report number 18, this is in the book, talks about a simplified severity score for giving prognostic information to patients. And my patients do ask me, hey doc, what are the chances of the other eye getting this? And I think this is important to know. So if you have one or more large drusen, you get 1 point per eye. They don't, small drusens don't count for anything. If you have any pigment changes, it's a point for each eye. And then if you don't have large drusen, but you have intermediate sized drusen in both eyes, that just gives you 1 point, or like a half point per eye, if you will. And then if you have neovascular AMD, that gives you 2 points for that one eye, and then whatever you have in the other eye. I don't talk about 10-year risk with patients, but it's there. This has been well evaluated. The 5-year risk, if you have 4 points, so let's say you got bilateral large drusen and you got RPE changes both eyes, they have a 50-50 chance of getting advanced AMD in one of their eyes by 5 years. And then you just half it from there, 50%, 25%, 12%. Nobody's really asking you when they've only got one risk factor at 1 point. So that's that scale. I'm not going to spend too much time here. I think this is interesting. This is where the future is. But Srinivas Sada's group has looked at OCT. What we just talked about were basically clinical findings on your like a fundus picture. OCT findings could more accurately, we would all hypothesize, predict advancement of macular degeneration. So they looked at this, and he evaluated. I'll show you in the next slide. But what I think is really more important is what he used as his markers for prognostic implications or worsening. And the one that he found that was the most predictive is the hyperreflective foci within the retina. Okay, so that's the second one up there. Drusen volume was actually not that helpful, the first one. Third one, hyporeflective foci within a drusenoid lesion, and the reticular pseudodrusen, which we already talked about. Fellow eye, so there's their point system. He did not, again, maybe I didn't read the article well. I could not find his time horizon. He had about 28 months of follow-up, so I'm guessing it was about a year. But he categorized them. You can see the numbers there. Again, this isn't in the BCSC, so we'll move on. Okay. Lifestyle modifications. What can you do if you've got dry macular degeneration? Well, the book says stop smoking, lose some weight, and get your blood pressure under control. Not a lot. I'm sure those are all, this is some good ideas, right? This is not in the, I hate to do this, but this is just kind of the thing I do all day long. So exercise makes a really big difference. In one study, one big meta-analysis of 7 studies, it might have a protective effect of up to 41%, preventing you from going onto the wet form. Okay, none of this stuff is actually slowing down the dry form, as far as we know. We're just talking about preventing progression to the wet form here. And speaking of which, I do send a lot of patients to low vision. I think that is critically important. They might be able to do way more than I'll ever be able to do for these patients. Proper amsler vigilance is also very important. AREDS 1 had a bunch of patients, 4,700. Here's all the micronutrients. We're not going to talk about those too much right now. Those conferred a benefit of 25% reduction in their risk for progression to wet AMD over a 5-year time horizon. I quote that number to my patients all the time because they're like, oh, vitamins, and they're expensive. You're on a fixed income. These vitamins are proven to help more than just about anything else. And we'll move on. AREDS 2 basically said, okay, well, beta-carotene, we knew beta-carotene was harmful. They kind of stopped that midstream on AREDS 1 because people that were smoking were getting a higher rate of lung cancer, right? And so They added in lutein zeaxanthine. This was not available commercially when AREDS 1 was around. They wanted to use it, but they couldn't, so they put it in AREDS 2. We all thought omega-3 fatty acids were important based on survey data looking at fish intake, because that does appear to be helpful, but just taking the omega-3 fatty acid supplements or the one particular formulation that we used in AREDS 2, not helpful, okay? And then zinc, 25 milligrams, we tried to lower it. It was not quite as good as 80, so you'll see different formulations out there, 25 or 80. I think either one's fine.
Do you vary like AREDS 2 for non-smoke, like for previous smokers and AREDS 1 for non-smokers?
No, I do AREDS 2 for everybody. And I'm actually pretty specific. If you go to Walgreens or Walmart, you'll see like a bunch of choices, and some of them are not good choices. Some of them don't, like, will have not enough lutein zeaxanthine, or they'll have too much. It's hilarious to me, but you know, Bausch & Lomb, Preservision, AREDS 2, that one's pretty good, green and blue label. But even B&L's Preservision has multiple different labels, like, oh, the smokers formula, non-smokers. Just go with AREDS 2 and go with the blue and green label at B&L, or, you know, something like that. Ocuvite, iCaps, they all have reasonable formulations. I just find that most of the patients are familiar with Preservision. Good question. We don't do macular laser photocoagulation, certainly not for dry AMD, and very rarely for wet AMD. Rheophoresis was tried, lamopilizumab, big $1 million disaster. Okay, this is important for you guys to know. And I don't know when it dawned on me, but one point I realized I was telling my patients this, and they're like, oh, I thought I had this form. You know, going from dry to wet is not like, this is a terrible analogy, but this is the best thing I could come up with, going from a caterpillar to a butterfly, all right? It's not like you're one or the other, all right? It's more like you've got, it's more like you've got hail damage is the dry form, but the wet form, the water's actually leaking through, the rain's leaking through your roof. At the end of the day, if you have the wet form, you still have the dry form. It's kind of, in English, you don't usually have things that are both wet and dry at the same time. But that's what we're talking about with wet macular degeneration. And it's really important because when we first started putting people on anti-VEGFs, they're all getting better, but then they're only getting so much better. They're not getting, some of them are getting back to 20/20, but then over years, if you look at the CAT 5-year data, which we may or may not get to, you know, 50% have 20/40 or better. That means the other 50% are worse than 20/40. And that's not because of wet macular degeneration. It's because they still have the dry form going on. I mean, yes, some of them do have subretinal fibrosis, maybe geographic atrophy is worsened by VEGF. But the reality is that they have both. And in my opinion, they should still take their AREDS vitamins. That's a whole other story. But that's kind of my understanding of wet AMD. So presence of C and V is a defining characteristic, right? Patients will come in with a little kidney bean scotoma or a new wavy line. A lot of dry macular degeneration patients will come in with a new wavy line too and still not have anything. And then they can also just get decreased vision. Everything's gray. Very frequent patient that I see. Probably the most common diagnosis I see now, whereas I didn't see it at all in Africa. Literally 0 cases of wet macular degeneration or dry, a few drusenoid sort of phenotypes, but nothing like this. So I was in a very specific part of Africa, by the way, that was not very cosmopolitan. It's a very set genetic population, just didn't have the genes for it. So you've got certain signs listed here. Let's keep on moving because you're going to see most of those. All right, I hate this classification. It isn't super useful right now in terms of treatment, management, etc., but I think it will be in the future, and it's still in the book. So type 1 neovascularization, think of this as being the deepest one, right? So you get type 1, type 2, type 3. Type 1 is underneath the RPE. Type 2 is just on top of the RPE. And then type 3 is originating from a deep capillary retinal network, retinal angiomatous proliferation. The top two are both true C and V. This third one is almost like a form of NVE. Don't ever say that. I shouldn't even say that out loud. But it's like a retinal neovascularization. It's just a weird one. If you look at fluorescein angiography, and we do this less and less now, can one of you guys shut that door? I don't know if that's some noise from the hallway or just in my head. But classic C and V, you know, early on, it's well defined, and later on it expands beyond those borders, the borders become a little bit less distinct. Occult, you kind of have two major patterns. You've got this fibrovascular PED, irregular elevation, progressive sort of stippled leakage that, you know, worsens over time, and then you get this late leakage undetermined source. And then type 3 C&V, harder to characterize, focal hotspot with late CME or pulling into a PED. So occult is kind of like a type 1, or it is a type 1. Type 2 is classic in general. And then, you know, I'm not going to ask you guys what we're seeing because it's not that high yield. We got a little bit of RPE depigmentation, and we have a hyperopic disc. Hyperopic disc is also more common as opposed to myopic disc in patients with AMD.
In that last photo, if I saw that, I wouldn't know that that's not drusen.
Right, it's not a great photo. No, I know. It's not. It was. I think it's a photo from one of my mentors at Wills. I'll use a laser here. That is definitely a drusen. These two might be right in here. This maybe is some atrophy. I agree. This is not the best one. I mean, I showed you an IDON photo earlier, which is a SLO photo, scanning laser ophthalmoscope, and that is it's kind of like a real high contrast, but also has not all the wavelengths of a normal color photo, but it really highlights RPE atrophy. This one, maybe that's some depigmentation. I agree with you. Not this is like your typical OCAPS kind of picture where you're like, I don't know what they're talking about. I think there might even be some subretinal fluid here, but I can't tell for sure. So, but here you see some stippled hyperfluorescence, and then later, it's not that much different, but much later, it kind of leaks out beyond there. So that blue arrow, did I label these? Nope. That blue arrow was an occult CNV, and those little yellow arrows are small PEDs. The hot cross bun sign, if you heard of that, that's what these little guys are on the right, the yellow hot cross bun PED. Okay, so another eye. Can't really tell what's going on. It's a little bit washed out. Maybe there's, you know, a grayish, greenish colored membrane, inferior temporal. And now here we see an early fluorescein. You see a well-defined lesion that's hyperfluorescent. And then later on, it leaks beyond those borders. This is more classic. Okay. All right, so I am gonna ask you guys on this. So what on this image, what findings, what information can you garner from this image and tell me? We'll just kind of go down the road. So
There's some fluid
Rich?
between the RPE and Bruce membrane.
All right, so there's fluid here. Is that what you're talking about? Okay, and what category, what would you call that if you were to see it?
Type 1. You guys are type 1?
Well, yeah, it could be. It's hard to say. What other imaging would you want to see before you called it a type 1 CNV?
Fluorescein angiography.
Right, so fluorescein, right now you could say it's an elevation of the RPE, okay? All right, what else? Let's see, Edward, go for it. What do you,
Drusen, like,
yeah, there's some drusen. Let's see, can I get an arrow on this thing? Probably not. Oh, yeah, there's an arrow. So yeah, some drusen right here. All right, and then we got Alex, what do you see? And you can name anything. Any information at all you can get from this.
yeah, maybe some atrophy of the choroid.
Maybe it's, you know, so
like
you know, I don't really talk about that. You're talking about this little area right here, some RPE atrophy. So the choroidal thickness is actually not bad. In general, I say that it should reflect more or less the thickness of the overlying retina. That's not actually true, but in general, it's not a bad marker. But you don't see a lot of atrophy in terms of thickness in this particular image. Edward?
The eye is always junction disruption.
Okay, so I don't use that term anymore.
Ellipsoid zone.
Thank you. Ellipsoid zone. All right, so you got ellipsoid zone. What were you saying about the ellipsoid zone?
Disrupted. It's like
Right, so we see it pretty
Yeah.
continuous here, and then it's kind of like, I don't really see it right here. Don't
And
see it
again,
here.
and again there, I think.
Yeah, and you do see it here, and you can see the ELM. Do you know what the space between the ELM and the ellipsoid's called? There's a great interactive thing on your BCSC book. If you go online, it's like www.aao.org/BCSC, blah, blah, blah. But it's in the book. There's a little QR code, but it's got a little interactive thing. You click on the dot. And so between the external limiting membrane and the ellipsoid zone, it's called the myoid zone. Okay, so it's a hyporeflective region. And then do you guys know it's between, have you guys had an OCT lecture yet this year? It's okay.
From July.
Okay.
Yeah, maybe.
Okay, anyway, not in January though.
Not January.
Okay, all right. So right below the ellipsoid zone, again, we're just talking about photoreceptor anatomy. You've got an interdigitation zone that's right between the RPE and the ellipsoid zone, and you can't always see it. In this case, I would say, you know, maybe this area here, but I don't know if anybody can see that. So, all right. And what else can you guys say about this image? Well, I'll quit trying to squeeze this orange. So I'm just going to kind of label everything. So the first thing you can tell is this is a right eye, unless I photoshopped it or something, right? So it's a right eye because we see the nerve over here. We have a thicker nerve fiber layer. Even if we didn't see the nerve, we'd say, okay, we see a thicker nerve fiber layer, so this is probably the right eye. There isn't this is a partial PVD. There's no VMA, no vitreomacular adhesion. That's important too. We'll talk about that in a moment if we get to it. We're running out of time. There's a little bit of an ERM, both nasally and temporally. PED here. Now, I'm just going to call this a PED. There are some signs of PEDs that make them suspicious. If they have an irregular elevation, this one's got a pretty nice smooth dome, or if they've got some reflectivity changes within them, so like a little hyperreflective mass just on the interior side of that. But I would call that a non-suspicious PED. You see some RPE atrophy here, and there's kind of 3 criteria for calling it RPE atrophy. You see hypertransmission of the light into the choroid space. See those both dipping down like little daggers? Number 2, you see loss of the RPE or thinning of the RPE on top of that. And I don't always see it. Sometimes I'm surprised by how much RPE I can still see and have atrophy. And then number 3, you have some photoreceptor atrophy. So I don't see, we already mentioned earlier, the ellipsoid zone just above those, so RPE atrophy. There's a couple of hyperreflective foci here, but really only one of them counts because it needs to be about the same reflectivity profile as the RPE. In other words, as bright as the RPE. The one on the right, not bright enough. The one on the left, bright enough, almost contiguous though, with maybe some RPE pigment migration, so it's not a perfect hyperreflective foci. So there you have it. This is a patient that came in, I think he had a little bit of metamorphopsia. And here's another patient. I just wanted to show you what a hyporeflective foci looks like inside of a drusen. And so you could see a little bit of a dark spot here, and that is also a risk factor for, this guy actually has CNV actually, for CNV, for atrophy, for photoreceptor loss. So, all right, left eye, we kind of went over a few things already. This is that suspicious lesion that I was talking about. The RPE is still kind of, or the PED is somewhat dome-shaped here, but you see this lesion. We obviously have subretinal fluid. Let's go through. Here's our pigment epithelial detachment, subretinal fluid. That's our most likely our CNV. And then we've got SHRIM, subretinal hyperreflective material, which was not even a word when I was a resident, so getting old. Okay, this is a patient who came in with metamorphopsia. He's like 70 years old, healthy guy. You see some drusen. Not a lot in the way of RPE changes, right? He's got a little, not much else going on, honestly. All right. Oh, I should have asked you, what do you want to do first? OCT. It's easy, it's non-invasive, why not? So here you see this, kind of underwhelming, no obvious intraretinal or subretinal fluid. We could look at some more scans. What is the best choice for the next test? This is a loaded question. FA is not a wrong answer. OCTA is my favorite in this scenario because it's non-invasive, and honestly, I have a low pretest probability of this guy having a CNV. Now, we could go back and forth, and it wouldn't be productive conversation, but you know, OCTA is going to supplant FA to a large degree for a lot of people. It already does for me for macular degeneration because there's not a lot of diagnostic dilemma here. This isn't a talk about OCTA, but suffice to say, I don't use FA very much unless I'm having a diagnostic dilemma or I'm about to do PRP. I really don't like to do PRP in retina that's perfused. Makes sense, right? So I did know CTA. And what do you guys think? Do you guys understand how OCTA works? Plus or minus? What were you say, Edward? Why don't you say that and I'll tell you my spiel about OCTA.
It's basically like it's almost like it looks at different levels of the retina, and then like for example for that one there's like some cloudy appearance, like looking like, for me it looks like neo.
Mm-hmm.
So basically you can see like how vessel goes to different layers, and you can tell whether there's in the beginning of neovascularization. So okay, let me just
Here, why don't I start over? So you guys haven't had a lecture on OCTA probably. So first, to understand OCTA, you have to first understand OCT, and I didn't set up this lecture to really explain it very well. The bottom image is called a B scan, okay? That comes from the old ultrasound days bright scan, right? But basically, the B scan is composed of, we'll say, 512 A scans. You know, an A scan is just one little line. You basically, it's, again, getting back to, this is like getting down to the patient level in terms of explaining it. OCT is like I'm shining a light in, and things are reflecting back, and I'm measuring how long it takes for that light echo to get back, that delay, and then I'm measuring just how bright it is, right? So things that are more reflective, like a mirror are going to have a really high amplitude in terms of like how bright the dot is, and things that are like felt aren't going to return anything. So if I have mirror, felt, mirror, well, the felt's probably going to block anything behind that, so I'm not going to see anything deeper. So you have some attenuation of the signal beyond that. And so that's a B scan. So we take all those A scans and we line them up, and that's our B scan. OCTA is taking those B scans, and we do this with structural OCT too, and then we take a bunch of B scans, line them all up into a big cube, and then we look at them on FOSS. So we're taking a summative, in a sense. Everything on right here is showing up right on this line right there, and then we're doing another B scan to get the line below that, another B scan, another B scan. Then what we're doing is we're actually slicing the B scans. Again, I should have made a lecture for this. And so that we're only seeing a certain layer, like the topmost layer, like the nerve fiber layer or the deep, the RPE layer. That's just still OCT structural. The part where the angio comes in is when you are doing a scan and the light comes back to you, and at a certain depth, you have a bright light, dark light, bright light, dark light. Okay, so you take like 5 scans in a row really quick. And then you notice at one particular point, you're getting like a twinkle. Like sometimes the light's there, sometimes it's not. We have taken that as an interpolation, not interpolation, that's not the right word, but we have interpreted that to be a blood vessel, and it's been verified. Because those red blood cells are running through that blood vessel, and they're sometimes shining the light back, sometimes not. Sometimes not. When you look up at the sky and you see twinkling stars, it's sort of like some gases are moving around, and sometimes you're getting the light coming at you, and sometimes it's not. So we're seeing twinkling. And what we're doing then is we're taking that twinkling signal and we're assigning it its own reflectivity. In this case, we're making it brighter. And so that little spot did I circle it? Yes. The editor was talking about, it kind of looks like a C and V. You see these little blood vessels. And so the great thing about this is it doesn't give us much in the way of function. Like it doesn't tell us what's leaking, what's not leaking, but it shows us blood vessels and where they are. I will say it is a pain. This is a Cirrus. I hate Cirrus in general. It's the only OCTA platform we have right now. Another story. And you kind of have to take the segmentation lines, like see that line down at the bottom? There's 2 purple lines going across on that B scan. That's where our on-FOSS image is coming from, and we're plating that out. So we're actually looking at more or less the choriocapillaris layer, but you still see some retinal vessels flowing through there, right? That's because there's a lot of projection artifact, because you don't really get a perfect depth resolved image. You can, but you have to correct for it. So is that C and V, right? That's the question. Can we tell from this image?
By your face, I'd say no.
Yes, exactly right. No, we can't tell. So I move my B scan. I move that little blue line that's telling me where my B scan at the bottom is going, and look at this. Did I circle it? Yes. That is RPE atrophy. So actually what we're seeing up there is not a C and V. We're seeing choriocapillaris, or actually not choriocapillaris because that also atrophies with RPE, but we're seeing some choroidal sort of shine through. So it's a window defect. So you can get tricked. And you need to know how to interpret these. There's a lot of people doing crazy stuff with these right now. And I mean crazy in a bad way. Okay. So here is a patient that has wet macular degeneration, and as part of a special treatment protocol, we're doing OCTA every time she comes in. And she's going to get 3 anti-VEGFs in a row, and then we're just going to watch her. So this is her baseline. And we have the B scan down below. You see an irregular PED. There's some subretinal fluid. There's shrim. And up above, you kind of see this area that looks like C and V. It's abnormal. You don't normally see blood vessels forming little fronds or C fans like that. I did a 3x3 in addition to the 6x6 on the on-FOSS angio, and it's a little bit easier to see on the 3x3. So I put that in there for you. That's what that is. So 30 days after, what happened? Hard to see. It went away. It's that anti-VEGF working. Great. Well, we did our 3, and then 12 weeks after the 3rd one, we could see these little yellow circles showing us, well, there's nothing at 12 weeks, 16 weeks, maybe there's something. 21 weeks, I think there's something. And then I also noticed there's another little lesion starting to form. Well, there's no fluid on our OCT, on our structural OCT. Look down below. There's no subretinal fluid. There's no intraretinal fluid. Do you treat? Do you not treat? This is a gray area. These are subclinical. I see patients like this. Like let's say I'll have a patient present, and they'll have something similar to this slide, this far right picture, and they've never had a treatment. Those are really hard to decide. There's some people that are treating those patients. I did treat this patient at 21 weeks afterwards because I have evidence of recurrence in a context of wet macular degeneration history of treatment. If she was treatment naive, and I have a few patients like this, I just watch them closely because I think some of these subclinical CNVs, I'm not sure what the proper term is going to be, intermediate CNV or something like that, they wax and wane on their own. And when you inject somebody and they get endophthalmitis, and it's a real risk. It's 1 in 5,000, but it's a real risk. We're running out of time. Do you guys have to be somewhere? Probably. You're all residents. You all have to go. All right, let's see if we can get to a good stopping place. CNV, we'll just run through this whole thing. And then, yeah. Okay, so polypoidal, it's a variant. It's aggressive. There's a lot of different studies. I don't use PDT on it that much anymore. I'm usually just anti-VEGF monotherapy. We've got a few more slides. And then wet AMD, we already talked about treatment. Angiogenesis, don't memorize these activators, inhibitors, but I think this is important. What does VEGF do? You guys are about to go, so I won't pimp you anymore. It stops or prevents apoptosis in endothelial cells. It's SLAP. L is lymphangiogenesis. A, we all know. And P, vascular permeability. It was originally called the VPF. Nobody ever gives Sanger credit. The first guy who described it called VPF, vascular permeability factor. They changed the name later. Okay. Nobody uses Macugen. We're not even talking about it. Bevacizumab, ranibizumab. I'll just put these online. You guys can look at it later. And then aflibercept came out in 2011. We haven't had anything since then. We expect something this year. Major studies to know, none for Macugen because it sucks. And Anchor Marina, overwhelming visual improvement, changed everything back in 2005, 2006. Bevacizumab was found to be non-inferior to ranibizumab in a bunch of studies. And it may actually, well, I'll get to this in a moment. And so the View 1, View 2 for aflibercept got it FDA approved for AMD. Used less frequently than ranibizumab. Excite and Pierce showed us a quarterly, these are all in the book, that's why I'm putting them in here. Quarterly treatment is not good. Horizon showed us that PRN treatment, if you have too stringent of criteria, is not good. Their retreatment criteria were terrible. But PRN in general is risky. 5-year data on the CAT, 50% of folks had 20/40 or better. We mentioned that earlier. Your GA development or increase may be worsened by anti-VEGF. That's really scary. We don't know what to do with that. And ranibizumab is worse than bevacizumab with atrophy, at least according to the CAT study. And then don't do combo therapy in general with PDT. So I'm just going to fly through this now. Hyaloidal separation may need fewer injections. That's a good thing if you don't have VMA. ERMs require more injections. It's never too early to get somebody into low vision. And you guys you will know complications. The main thing is endophthalmitis. Inflammation is a real issue as well. Endophthalmitis is 1 in 5,000. It's maybe in residents it's higher. Sorry, guys. Probably not that much different. It's probably lower than 1 in 5,000 with prefilled syringes, maybe 1 in 10,000 in some preliminary studies. There's risk, systemic risk. That's a whole other lecture. Here's a lot of other causes of CNV. Ocular histoplasmosis syndrome. That looking at the OCT may not know if it's wet AMD or not. As soon as you look at the photo, you realize this is a guy I treated last week. He's got a lot of punched out lesions. This is no questions. Ocular histoplasmosis. Angioid streaks. Here's your classic differential, Pepsi. Pseudoxanthoma elasticum is actually important. You could save somebody's life. If you see angioid streaks, you get them diagnosed with PXE, they have the mutation, they're at risk for peripheral arterial disease, MIs. I get them connected to a cardiologist right away. And this is a patient, it has angioid streaks, got hit with a bungee cord, so they need to wear safety glasses. Several months later, things were better. You just watch. We don't treat with anti-VEGF if it's just a blunt trauma like that. CNV is different, obviously. And then pathologic myopia, another patient of mine. Very underwhelming picture, a little bit of subretinal hemorrhage. OCT is also underwhelming. Just a few anti-VEGFs for these folks. And this is from the book. I don't know if it's worth memorizing. Probably not. Just a bunch of different categories of causes of CNV. And I think that's it. All right, you guys are troopers. There's the references. Have a good day. Questions before we adjourn?
We had to rush through a bit of it.
Yeah. All right. Thanks, Edward.
You comfortable sharing PowerPoint?
Oh, sure. Well, what I'll do is I'll actually put it on YouTube, and you guys can just take screenshots of it. Yeah,
Thanks.
Absolutely. And I didn't talk about my treatment pattern, but treat and extend is pretty much the standard of care these days.
Like 1 month, 3 months.
So yeah, I start at 4-week intervals, and then as soon as they're fluid free, I go to 6 weeks, and then I'll go to 8. I'll go to 10, and I'll go to 12. Sometimes I'll stop. There's a pattern called Trexis, or I call it Trexis. I don't know if anybody else does. Treat and extend and stop. Some people can stop. It's a small percentage of people, though. But I like to give them a try. As soon as they recur, I go back to, if they recurred at 6, I go back to 5 or 4 weeks. and I just kind of capture the interval. I tell my patients all the time I can manipulate two variables. One is the duration or interval time or the duration between appointments, and I can change their medication. So some people, want to go quarterly, and I tend to put them on EYLEA since it lasts the longest.
Yeah.
Some people have a stroke history, so I might put them on Lucentis because it has less systemic half-life, but it also may have a higher risk for stroke, ironically, in some of the most recent data. So it's a big struggle for me picking the right drug, and I do change over time based on, like, we had an epidemic of intraocular inflammation with EYLEA about a year ago, so I switched almost all of my patients off. So anyway, but yeah, I'll put these online, and I'll send a link to Lauren or something like that. So
that'd be great.
yeah,
Appreciate it.
you bet.
Sorry for the late start.
No, it happens.